Okay, welcome to Spine Conference. Yeah, we're working.
Okay.
All right, let's get started because I have to leave on time. So today's discussion will be infections of the spine because Paul Asdurian asked me to do that, and I do everything he says. Right, Paul? I don't have a
great case.
Do you? Okay, give me the. So this is an illustrative case of a man from 2 weeks ago, about 2 weeks ago. 56-year-old man with lower thoracic pain, and he had pain 5 weeks ago, which radiated to his chest. He had difficulty sleeping. Would sleep on the couch. He thought he had the flu. He had anorexia, sweats, hot and cold sensation. He's a very healthy man, no medical problems, and he runs 5 miles a day. He's a computer scientist. He at the same time that he got the sweats and fevers, he had right foot cellulitis after cutting his foot on a saw helping his daughter with a renovation project. And he got extremely cellulitic. He went to the emergency room and was given 10 days of Bactrim. During this whole time, he was very sick, and he said he lost 10 pounds. He said he didn't eat for about a week or two. But then things improved, and then he was fine, except his back pain persisted. So he went to his primary care physician, ordered some x-rays, and just quickly, somebody tell me what the x-rays show, if anything. Who can, somebody? Just what it is, just be quick about it. Yeah. And look, do you see anything at the arrow? You can say no. Okay, and the lateral looks pretty normal too, right? So the x-rays are negative. So the next step was an MRI.
I would go back to that. I don't think the x-rays are
Okay.
Anybody see anything of the x-ray that might be concerned?
There's a soft tissue shadow on the right. But maybe not there on the left. On the 18th, I'm not sure who's making that up.
Yeah, I mean, it's quite good, especially with a soft tissue, density, in the shoulder. What do you think? Did you call that anything?
In the mediastinum, you mean?
I mean, do you think does this look like there's a swelling right here? Or is this a normal line that you see there? Is that abnormal, or is that, I mean, could that be something that's...
You're making stuff. Let's keep moving. Come on. Okay, we got a lot of stuff to go through today.
Think so, okay.
We have 5 cases to go over today, including...
Five cases?
Yeah, 5 cases. I'm not messing around today. Let's keep moving.
All right.
Okay, so what do you see on the MRI?
So there's an area of increased signal. I think it's helping labeling it the
T89, yeah.
disc space.
Yeah. So there's something within the T89 disc space, right? And is it extending anywhere?
Yeah, it extends posteriorly and inferiorly into the T89.
Okay, so these are 2 views of the thoracic spine. So that's one view on the left, and there's another cut on the right. What's that big long ribbon thing going up and down? Spinal cord. And this.
There's some loss of the CSF.
Yeah.
Interiorly.
Yeah. So.
What?
What is that?
Interiorly, it's from either swelling or a mass or some sort of CSF effacement.
Yeah.
What do you think it is?
Probably either infection or tumor extending from that area of increased signal.
What gives you increased signal on that T2 image on the MRI, that's pathologic, in the middle of the disc?
Osteo or discitis.
Yeah, infection.
Yeah.
Right.
So it looks like it's emanating from the disc space, right? And it's going into the epidural space, and it's compressing the spinal cord. So it's some kind of lesion. Okay, let's keep going. So what are your thoughts, maybe somebody else, on the fat suppression images? Anybody else?
What are you seeing here?
Fat suppression images.
T2 fat suppression.
We have a lot to go, so just keep moving.
Yeah, we're still seeing hyperintensity. It's clearly whatever is going on there. The infectious process is infiltrating into the canal.
You don't know it's an infection yet, okay? So let's just say whatever it is. So is it just a little bit of the disc? Is it emanating from the disc, or is it the whole body?
The bodies are affected.
The whole bodies, right? All of them. And it's going into the epidural space, right? Okay, let's keep moving. Paul, I'm sorry to step on your toes a little bit, but okay. So Dr. Samir read this MRI scan, and I respect him very highly. because he's really smart and he's really careful.
He's here.
And he's here. And I love Dr. Samir. So he made a point that this process was expanding past the bodies. So you want to elaborate a little more, Dr. Samir, or
Well, you can see that on the axial T1 images on the top, two views, and the axial T2 image on the bottom, two views. So fat is our friend in this image. So yeah, you can see all of the low T1 signal. It's basically, you can say slightly hyperintense relative to the musculature, but it's going all the way around and outside of the vertebral body. And on the two sequences on the bottom two, it just happens to be hyperintense. So, based on this appearance and also how it enhances homogeneously on the T1 post concept, this would design a phlegmon. So phlegmon is basically when you have an infection that is still in a homogeneous state before you get the capsule formation where it becomes an abscess. But again, when I read this, I didn't have the same information as you guys, but I also found out about another finding in the lung. So it made me think about three different.
there was a mass in the lung too. We'll get over that, but there was on the MRI. So, but it is expanding way past the bodies,
Yeah.
which it didn't look like the infection was destroying the bodies. It looked like it was just emanating from the disc space. So, I mean, this in my mind, it could be a tumor because it's expanding like that. It's infiltrating. So then he was. Here's the CAT scan. I don't know how do you guys do it? When I'm in the thoracic spine, I always order a CAT scan from the sacrum up to find the lesion, and I count up with needles. Do you guys have any other tricks for the thoracic spine? Because thoracic spine is hard to know where you are intra-op. Do you guys have any other tricks? That's what I do. So I put a needle into C4. I put a needle into not C4, L4. A needle in L2, a needle in L1, a needle in T11, and I kind of like leapfrog up to the lesion. Do you guys have any other tricks to get to T8 or T6? Same thing? Okay, so that's why I always get a CAT scan with the sacrum. Otherwise, there's no way to count intra-op. So who wants to say what the CAT scan shows? Resident or fellows? T8, T9 is the one with the big black spot.
Yeah, it's pretty much the same thing reproduced that we saw in the MRI.
So it's destroying the end plates and going into the vertebral bodies, right? And you can see also on the right, it's a little faint, but you can see there's an epidural component. Okay, so the way this played out, they called me Tuesday night, a school night. I had homework to do. I had a bunch of stuff at 8 o'clock. And I said, well, just, first thing in the morning, unless it's an emergency, neurological, the nurse called me from the office. I was like, I've never seen the patient. Just send them to the emergency room first thing in the morning or tonight if the patient thinks so, because I didn't have the MRI. So he was admitted. So I did a metastatic workup, triple phase bone scan, the entire body, a CT CAT scan, chest, abdomen, pelvis, and blood work. So this is the bone scan. And because we have a lot of things to go over, I'm going to go quick. You can just see that the T8, T9 lesion lights up, and nothing else lights up in his body, just T8, T9 basically. And so his blood work was, white count was 10. He had elevated SPEP levels, not severe, but slightly high. You can see immunoglobulin A is 546, free kappa's high. Lambda's high, SED rate's 115, C-reactive protein 67, globulins are high, 4.9, skeletal survey was negative, bone scan was negative. The CAT scan with Dr. Samir we discussed, he had a left lung mass 2.7 by 1.7 centimeters. So it's something that needs to be looked into. So the problem is so far is a 56-year-old man, back pain, no myelopathy, no extremity symptoms, T8, T9 lesion. He has a small epidural abscess. We didn't talk about that, but let's just go over it. It's kind of important. So you see bottom left corner. You see can you guys see the abscess? What's your thoughts? Well, you can see how much pressure there is on the spinal cord, so just memorize that. And and it's expanding past the body. So the question is, what I want to ask an attending, what next? Would you do a CT guided biopsy, open biopsy, laminectomy T89, right-sided T89 laminotomy, or a big fusion, or any other surgery, or how would anybody else approach this? Well, maybe Dr. Mesfin, are you awake enough to discuss? So T89 lesion, neurologically intact, healthy guy, T89 epidural, maybe epidural abscess, maybe myeloma because the SPEP's slightly high.
It looks like infection to me. The space is involved. That's usually not the case with tumor. Doesn't quite have the appearance for myeloma. But I think it's probably a disc-based infection that's spread into the bone. That's my guess. This patient kind of falls in the gray zone. The general rule for osteomyelitis without bone destruction is medical management. The general rule for an epidural abscess is surgical management. But here you've got a healthy guy who's neurointact and back pain. So you could argue to confirm the diagnosis with a CT-guided biopsy or some type of image-guided biopsy, get cultures, sensitivities, put them on antibiotics, get infection markers. All of the infection markers, saturate CRP, are probably the most sensitive. And if he's responding, continue to watch him with weekly labs. And if he doesn't respond, go in and decompress. Basically treat it like a tumor procedure. I go from the front, pick up the infected disc, evacuate the epidural abscess.
Okay, so those are my exact thoughts. And I also talked to him. I said we could either open it, or it's possible this could be treated all closed. This man's a very educated man. He listened to every single thing I said. So, so that was basically my plan. So he had a CT guided biopsy, and the gram stain immediately said gram positive cocci in Paris. And so, the presuming diagnosis was infection. And this is the pathology, which we got back. So we put him on immediate vancomycin. And the patient said after 2 days of vancomycin, pain was better already. He could sleep. Everything was improving. So he said he didn't want surgery. You see if we could treat it. And he's at I told him at a moment's notice, call me and we'll open it up. But this could be treated maybe with antibiotics. And that whole thing on the left is the infectious process. It's the reactive vascular tissue, inflammatory tissue, and it looked like an infection. On the left, there's the bone, and you can see the reactive tissue going into the bone and multinucleated osteoclasts there. And you can see there's a high-power view of the multinucleated osteoclast. And this, you see all the granulation tissue. It's invading into the bone. So all of this is consistent with infection. And this is just what a myeloma would look like, just sheets of myeloma cells, which was not present in any way. So this guy has T89 osteomyelitis. So would anybody do anything differently? I'm just curious. No? Sounds reasonable? So I'm just watching this man. So I'm getting an MRI at 2 weeks just to see if that epidural abscess got bigger, because that will change what I do. Would anybody thinks otherwise or not do it, or reasonable? Yeah.
I was just wondering, all of his myeloma labs were slightly abnormal.
I know. So I talked to a pathologist. She said it wasn't high enough to think that it's myeloma.
Was
So
that maybe an MGUS or some of the precursor stages?
she said the path should be positive.
Okay.
So the path, she said there was no evidence of myeloma whatsoever. Yeah, I thought the same thing. That's why I thought it was myeloma with an infection, which I've seen once. So immunocompromised patient with cancer gets an infection at the myeloma site, but it wasn't.
The only danger with the follow-up MRI is what you're going to do with the information. If he's clinically doing well, but the abscess is there,
Surgery. Sir, I'm ready. It's surgery.
2 weeks? In 2 weeks, you still have epidural
If it's
abscess?
bigger, I'm doing surgery.
It's bigger.
I told him that.
regardless of how he feels.
Yes. I don't care. I'm ready to open it up. I'm not going to watch this. So if you guys read the literature, like 20 years ago, everything got opened up, but the literature now is pushing more towards medical management, and that was in that review article. Okay, so let's do another case. Now I'm just going to go over osteomyelitis. Now you guys can interrupt me if you want. This is a case that I saw in the hospital. Was disc space infection from a post-op very small epidural abscess. We put him on antibiotics, and this is what he looked like 2 weeks later. So this was an appropriately treated infection case of discitis, and you can see how rapidly the infectious process destroys the disc because it's avascular. This is just another example. So it's usually disc, like Mesvin said, it's disc-based process. So the epidural space, everybody knows, is full of veins behind the vertebral body. And these venous structures also invade the vertebral bodies. And on the right is Batson's plexus, which everybody knows is a big plexus of veins with no valves. And it was originally found by a man who put an IV into the dorsal vein of the penis of a chimpanzee. Why he did that, don't ask me. And then he pushed dye, and it went into the liver. But when he pushed on the chimpanzee's abdomen, Valsalva maneuver, it went into the venous structures of the spine. And there's no valves here, and that's how you get basically prostate cancer and things that go to the spine.
New York of 1951 Coleman, you were a man who did that.
You were a resident at the time, weren't you?
Yeah.
So, and how do the infections? How does it work? I mean, correct me if I'm wrong, but I think it's when the arterioles go from arterioles to venous structures, there's a sludging process in the metaphysis of bones, like in a child, and this is usually where the infection gets lodged into the bone, and it usually doesn't cross physes.
And capillary loops, they're called.
And capillary loops.
That you have in the metaphysis, but you also have in the end plates, in the cartilage, especially in immature patients.
And capillary loops. And thanks. And this is just, if you guys are interested, there's a big article on pathophysiology of osteomyelitis if you want to just copy it. It's in the slide share. So it starts in the vertebral body, and then it goes into the disc space in adults, and it rips through the disc space like we talked about. Now in kids have, under the age of 15, you have a vascularized disc basically. So it's a totally different disease process. And you can see here how the end plates are completely vascularized in a child. And this is a normal child's disc on pathology, and more of an adult that's slightly degenerated. So these infections usually present with just pain, but everybody has back pain, so it's very hard to know if someone has an infection. And usually they do not have a fever. Blood cultures are positive half the time. The organism is usually Staph aureus. Non-operative candidates, if they're young and they're improving and they have a normal immune status. Comorbidities that are very serious are people on steroids, diabetes, cancer patients, rheumatoid arthritis patients, kidney and liver failure, malnutrition, mild dysplasia. Those patients are immunocompromised, and they, I think, need surgery, basically. They can really deteriorate quickly. The source, if it's not the skin, is usually the urine in people. And the imaging is X-ray, CAT scan, MRI scan, bone scan. Okay, so this is just one of the articles I said. I thought this was a great article to read, and I learned something from this. This is from the University of Washington, 128 patients, and they followed these people, and they wanted to see who failed. And the predictors for failure were four things: diabetes, C-reactive protein greater than 115, white count of 12.5, and positive blood cultures. If you have all four of those, 77% chance you'll fail medical treatment. If you have one, 8% chance. So my patient had none of these, but I thought this was very helpful in discussing risk factors. And this is another article, which was a classification system for spinal cord compression. I thought this was interesting too, from 2018. Mass General. They had, I think, 339 patients, and they classified how much the spinal cord was compressed. 1, 2, 3, 4, 5. 1 being just epidural space. 2 being it's compressing the CSF. 3 right up against the spinal cord. 4 the spinal cord's deformed, and 5 no CSF. It's just a grading system, and they found that obviously, the more you're compressed, the higher the likelihood that you present with deficits. And then those patients went immediately to surgery. But if you do not have any neurological deficits, like none, the amount of pressure on the spinal cord did not change your final function. So they were treating people non-operatively with spinal cord compression, epidural abscesses, and the patients did fine. But there's also evidence that if you fail medical treatment and then go on to surgery, those patients don't do as well as people who went to immediate surgery. So
The problem with classification was that, as you said, even if you had the type 5, that if you didn't have a neurologic deficit, they treated them with medical management and did okay. So it wasn't really prognostic. It's just more of it's bad if it's 5, but you shouldn't treat that with medical management if they're neurologically okay.
if anybody has any neurological deficit, no question these people need surgery. So these are just intact people, totally intact. I mean, it's a little bit interesting, but
The issue with the abscess is that it's not purely the pathophysiology of neurologic impairment. It's not just the compressive force of the abscess on the cord. It's also vascular insult. And that's how these patients can really rapidly deteriorate quickly. That's why Dr. Antonides says if it gets bigger, I'm taking him to surgery even if he feels well, because it's not, you can get a type 4 there and say, well, there's some compression, even type 3, well, there's some effacement of the cord, let me just watch this person. But they can go very quickly to the vascular portion, not just the extrinsic compression on the spinal cord.
then it's too late.
Yeah.
But
Nothing
there's no real data to say you should do an MRI, serial MRIs at any particular time. So the question is, we don't really know how many of these people get better, a little bigger or smaller, 2 weeks. No one has done a study where they've studied serial MRIs every 2 weeks to follow patients, with medical management. So,
That's why I asked you, when would you do the MRI?
well, that's why I think everybody who's treating medically, if they're getting better, they don't re-study them, so that we don't know. So to 2 weeks to do it, there's no data to show that maybe it gets a little bigger, then it gets smaller. But most people go on clinical, improvement with values and symptoms.
Yeah, there is no data. No one's ever done this.
For the residents, if you get somebody, say L4-5, destruction, similar, let's say this patient right here comes in on the medical service, has positive blood cultures growing out Staph aureus, and you're concerned about cystitis here, would you send that person for a biopsy?
They have positive blood cultures?
Yes.
I think you would still, I mean, you could assume that the organism is the blood culture, but I think you do want a confirmation of the
So we have
The
one
organism.
for biopsy.
I would still send that, even though technically you should have the organism just by the blood culture.
Then why would you? Technically, you should.
Could be,
Because that's what we do.
could be multi-organism and then you're missing something.
Anybody else?
I want to try to rule out any other sources before doing a biopsy.
Generally speaking, you don't need to. So you need one or the other. If you've got negative blood cultures, you've got to get a biopsy. But if you have positive blood cultures on that admission, then you don't need to get another culture. One of the issues with a lot of these patients is they will be empirically started on antibiotics by the medical service before they consult you. And so you got to get them off the antibiotics, for 48 hours or 72 hours, and then get the biopsy if you don't have positive blood cultures.
Commonly in the ER before anybody sees them.
Yeah.
So this was my case was lucky because I managed the whole thing. That's why I said no medical service, nothing. I'm doing everything, so I don't have to. There's no battle, Wait, this is a high level question for Dr. Mohit because he's the fellow. This is a 73-year-old woman who's presented with low back pain. This is a consult that I saw in the hospital. Low back pain, and she has urosepsis, and her back really hurts. She's obese. Here are the X-rays, the CAT scans. Just to make things quick, the CAT scan shows a L5S1 spondylolisthesis, a really bad disc. I mean, this thing can be, and she's had previous laminectomy surgery, and she's had chronic low back pain. So the medical services, what do? We tried to put her in the MRI scan, and she wouldn't fit, and she said her back hurt, and she's claustrophobic. Now what? Any tips? I'll tell you what I did, but any tips?
An open MRI.
No, I told her, put her back in the scanner. So she was really angry and she was frustrated.
I wish I had a patient whose back had that much fat in the back.
So I said, just put her back in the scanner. I don't care. So she went back in the scanner, and she had an epidural abscess. And I had there was a lot of antagonism against me, like, why do you need an MRI? The CAT scan's okay. And no, the answer is definitely not. I mean, the MRI, you need an
But
MRI.
Heath, where's the epidural abscess on that? Show it on the lateral. Where's the epidural abscess? Where do you see it?
It's not easy to see because she's wiggling in the scanner.
I'd say it's at 3, 4.
Yeah, well, the cartoon shows you too where the epidural
What
abscess.
about posterior though?
Oh, I didn't see the cartoon.
Am I? Do you think that's posterior
Yeah.
epidural abscess too? I mean,
Yeah.
Yeah.
I mean, this whole thing here to me looks like this could be
Yeah, it was.
epidural abscess as well, not just this area here.
Yeah, it was. You can see on the top right. You can see this abscess. It was all abscess.
There's a smaller one too. That
500 space just had more or is that the source? From the slip, from the spondylum?
That's from spondylolisthesis, the disc deterioration. So she had laminectomy, spondylolisthesis, and like a sigmoid type end plate, which is just from a spondylolisthesis. And then, so this is on the left is the surgery that I did. She had previous laminectomy, so I had to basically revision decompression and let the pus out. So that's a case where I learned is that you need the MRI. I mean, the CAT scan just doesn't work. Okay, so this is a case that came through recently. I'll read it unless somebody else wants to. This was a house case. 63-year-old woman who presented with neck pain, headaches, chest pain, 4 days, 6-month history of left lower extremity weakness, worse in the last 4 days. She went to the emergency room downtown for a day or two prior. She had a CAT scan which showed C4, C5 degenerative disc disease. She has a history of metastatic endometrial cancer, lymphedema. She's diabetic. She has a permanent central port for magnesium. And on exams, her left upper extremity was 2 out of 5 biceps, deltoids, 4 out of 5 wrist flexors. So her biceps and deltoids are out, are very weak. Lower extremity is 4 out of 5. White count's 28,000. SED rate's 122. CRP 318. Glucose 345. So just on this presentation, she has all the markers that we talked about that you cannot treat this medically.
You looked at BMI of 66.
66. Wow.
66, yeah. You should add
That's
that.
good. Okay, no, that's important. No, that definitely affects everything. So here, now the MRI is not great, but Mohit, do you know what the MRI? Can you tell everyone what the MRI showed?
I think it was an abscess collection present posteriorly in the posterior epidural space, right from the C2 or C3 to the L1.
Yeah, so unfortunately you can't really see on the sagittal cuts. It's not a good picture. But from C2, and this was at L1, you can see the epidural abscess dorsally and at T12. And you can sort of see you can see the abscess on the right side at C2 posterior to the cord. And it looks like most of that abscess is posterior to the cord.
The occiput, it actually was all the way up.
Yeah, all the way to C1 basically. Yeah,
It was from here down,
yeah.
and you could see all this posterior to this was all abscess.
Almost the entire spine.
It was the entire spine. That's
Yeah.
about L3.
So, I mean, would you consider a skip laminectomy in this case? You know, like every other lamina instead of full laminectomy? Would anybody do that?
I would consider any the least amount of surgery possible, but okay, we did. We did. We don't.
I don't know what you did. What did you do?
Okay, well, we actually on this patient, we actually did laminectomies of 2 down, so C2 to T2. Then we did mid-thoracic laminectomy. Then we did a lumbar laminectomy, and we put an epidural catheter from the laminectomy sites, sucked out pus, and then irrigated until we were able to irrigate from point to point on both areas. So basically we didn't open up the whole spine. We did scapula, so basically skip laminectomy. But cervical spine, she was so weak, we wanted to do a full laminectomy at that level. But thoracic, we basically left T3 to T7, and then did T8, T9 lami, and we just kind of put that epidural catheter and irrigated it until we got clear fluid. And then we went to the lumbar spine, did the same thing, did a lumbar laminectomy, and were able to irrigate out and not have to open up the entire spine.
That's good. That's clever. All right, let's keep. I have a couple more that's kind of interesting. Okay, this is. I want to see what you guys will do with this. 61-year-old man with neck pain and right hand numbness, and he has constant right hand numbness for 5 months. Sometimes the left hand, but he says the right hand is really numb. And the story is 6 months ago, he presented to the emergency room with terrible back pain. Terrible back pain. They got an MRI of the cervical, thoracic, lumbar spine, and it was negative. He got an infected toe, which also seeded the shoulder, both of which needed surgery. So he was septic. Okay. MRI was normal. So here are the x-rays, which, just to be quick, on presentation in my office, some degenerative disc disease from C5 to C7. No instability, obliques don't look too bad. Now, so I dug up the old MRI from 5 months ago because I was just curious. I wonder what the MRI looked like 5 months ago when this patient was septic. So who wants to see what they think on the MRI here? This was 5 months prior to presentation.
Try this, let me see.
The one on the left is now.
No, these are both 5 months ago. I'm going to show you a bunch of MRIs from 5 months ago. What are your thoughts? Is this normal? We say, hey, you're good.
He has some degenerative changes at mostly at 4, 5, 5, 6. He has what looks super early, sort of just behind C2 and C3, what could be a fluid collection or a phlegmon. Otherwise,
So that stuff anterior to the cord from C2 all the way down to C7, that's not CSF. I don't think so. It was read as CSF. Okay.
You can see CSF as an internal control at the
Yeah, at the brainstem. Yeah. So the MRI report was normal. Now the patient, mind you, was on antibiotics this whole time because the patient had a septic shoulder and a septic toe. So here's fat suppression images. Basically, this patient had an abscess from C2 to T2 5 months ago. And here are the axial cuts, and you can see they're not great images because they're always wiggling in the scanner because they have severe pain. But there's fluid anterior to the spinal cord from C2 all the way down to T2. This was 5 months ago. So, okay, so just when I saw this MRI, I was shocked. Would you be? When you saw this? Okay, so this is the MRI now. So what are your thoughts? Andrew, what do you think of this MRI now? This is now, so yeah, what I think was a cervical epidural abscess treated with antibiotics 5 months ago, and now this is the sequelae post antibiotics 5 months ago. What are your thoughts?
I mean, that collection seems to be improved. If it persists, I think it just persists at the uppermost level.
How about what do you think of the spinal cord?
He has a cord signal change at 2-3 that sort of extends down to beyond 3 and 4.
Sort of a diffuse spinal cord signal change, right? Myomalacia in the entire spine. And you can't see, but there's something posterior to the cord now. You can see it on that view on the sagittal cut. And here are all the axial cuts. So just start, if you start at C2, C3 and go down, and the last one's T4. But just to make do things quick, you can see there's spinal cord signal change in the center part of the cord. This patient also has a stenotic spinal canal. See the spinal cord's compressed? And look at C7, T1, T2, T2, T3. Spinal cord look normal there? It's posterior now there. Yeah. So what do you think happened? What happened in this patient? I think I have a theory. What do you think, Jessica? Why is it there now? Why did it go away? Like, what's the story?
I mean, gravity would be my own.
Yeah, gravity, yeah. And why is it posterior now? Well, when people are sick, do they sleep on their face?
No, on their back.
Yeah, so this lady was on her back for a long time, started walking. Yeah, so the epidural abscess shrunk and now is there at the cervical thoracic junction. And most of it's gone. It was treated with antibiotics. So now what? What do you do with this patient? Spinal cord signal change, stenosis from C4 to C7. There's a mass from C7 T3 on the left side compressing the spinal cord. So is this a phlegmon from gravity infection? How would you treat this patient? Anybody want to say what they would do? Right hand numbness. I'll tell you what I did. No, just numb.
Okay. But then, I mean, I think
C2,
you
but
should-
the abscess is gone up top. Look. The abscess where the mild spinal cord signal change is mostly gone. She's just stenotic. So this patient, he had pre-existing stenosis on top of the spinal cord, on top of the abscess. So basically the abscess is gone at the top and it's floated downwards, and it is compressing the spinal cord, but now it should only affect the legs, really, C7, T1, T2. His legs are fine. I don't know what the right answer is, but I'll tell you what I did. Does anybody have any thoughts? I would keep going. I just did nothing. I mean, I think if I'm going to do anything, it's going to be a C4 to T4, laminectomy fusion. In the face of an infection, man, he said, I don't want anything.
The question is it an active infection at this time, or was that just?
It's 5 months ago. No fevers, no chills.
Off antibiotics for 5 months, no symptoms,
Yeah.
just numbness. I think the numbness is probably coming from the C5-6 stenosis that the person has, and I wouldn't chase that T2, 3 mass if they're perfectly normal.
Maybe
and
sterile.
And the CRP is normal. That could just be residual. And it's interesting, this basically is consistent with the vascular infarct of the cord or vascular insufficiency of the cord causing a myeloablation. There's no stenosis there at this time.
No.
So seeing this change now, now that's evidence of vascular injury with epidural abscesses, I think.
Have you ever seen this before? I've
No.
never seen this
Interesting
before.
how bad that looks and how good the person is.
Yeah.
That, I mean, it's very, very, but I think your stenosis there at 5-6 is what's causing that.
On the
I
right.
mean,
Yeah.
yeah, that I would do more an ACF at 5-6. I wouldn't chase that.
I mean, I don't want to touch this person.
If you're going to do anything,
If you're gonna do surgery.
I think that's where the problem is at this point right now. I don't think it's that T2, 3 mass there, which is left-sided.
I mean, before you do any of that, wouldn't you have to kind of either confirm that that's a sterile, like, you can, if you
Well,
put an
if it's
ACF
off
or-
antibiotics and the CRP is normal, then the patient probably doesn't have an active infection at this point.
But would you be concerned about the hardware sitting next to potentially like a tough pocket if it is that? But we're saying it's not an infection.
Well, hardware there
but-
would be in the front, wouldn't be in the back. This whole
Well,
process
if you
in
do
the canal
posterior,
too.
if you do posterior and you irrigate out an abscess, we put instrumentation sometimes if you're unstable in the face of an infected
Yeah.
wound, you just have to clean it out and put them on the right antibiotics afterwards. But we do instrumentation in that situation if you have for stability.
Oh, this,
Sometimes you can have granulation tissue that looks and acts like an infection, an epidural abscess or phlegmon.
maybe
Like
all
phlegmon.
scar.
Yeah. And sometimes they just do follow up MR, and if it doesn't get worse, then it would support like a granulation tissue. And the patient has no signs clinically of any infection as well. But in this case, I agree with Paul is that the changes in the cord are probably related to vascular ischemia or injury from this infection. And on the X-ray, by the way, you can see the C5, C6 unstable level, the unstable joint, is really hypertrophy. So that's probably what's causing the weakness.
Look at the uncinate joint. Everybody know what the uncinate joint is? Uncas?
It was on
On the right.
There it is,
On the right,
You
yeah.
can see there.
It could be the whole problem. That little, maybe just do a framinotomy. Okay, so, all right, one more. You got to go, Paul. I got one more. Okay, this is the best one. You're going to miss the best one. This is a 52-year-old woman, first day in practice. Low back pain. Sarcoid. X-rays are kind of normal. MRI scan. Now she's had this low back pain. I saw her the first clinic I had at GW. L1, there's something in the L1 vertebral body. Do you see that? She had low back pain and sciatica. And there's also something in L4. There's something at L4, L5. There's something at T10 on the right. L1, remember the vertebral body is involved. It's in the spinal canal, epidural space. She's had this, and then L4, L5, it's in the left L4, L5 foramen. And her pain was low back pain, multiple segments, history of sarcoid, infection measures are all negative. What do you do? Anybody? Biopsy? Well, she had terrible leg pain. So I did a left L4, L5 laminopharaminotomy biopsy. It turned out she had caseating granulomas, and then when you look deeper, acid-fast bacilli. So this was a case of TB. So why, this was 1999. Why did this woman have TB in Washington, D.C.? Anybody guess in 1999? She was HIV positive because her husband was using drugs, didn't tell her, and she got it from her husband. And we checked her for HIV, and she was HIV positive as well. She didn't know. Okay, there's one more. You can go. This one's high level. This is not for you. Okay, this is the last. This is the last case, and I'm going to ask Brad what he would do in this case. This case is for Brad. 93-year-old man with low back pain. He has not walked for 2 weeks. 93-year-old, he hasn't walked in 2 weeks. Normally he's a normal guy, can walk, talk, lives alone, very functional guy. Hasn't walked for 2 weeks. The pain is so severe, he's on high dose opiates, and he cannot even move in his bed. And he presented in August, so this is like an old case. This was August 2011, just to get an idea. Now his history is he had low back pain a long time, for 10, 15 years. He got uroseptic in 2011, had a CT guided biopsy in May, which showed an infection, and he had a diagnosis of osteomyelitis treated with vancomycin. He was on vancomycin for 2 months, but now the infection is just rip-roaring. It's in you can see it's in the vertebral body, 54321 at T12L1, and it's all the way around the dura. He can't move. So let me just show you this. The history is great here. This was 8 years ago when he presented to the ER, kind of normal alignment. But 8 years ago, you can see this was 8 years ago. L3, L4 was severely stenotic. You can see the bottom right there. Severe stenosis at the fecal sac at L3, L4. This was like a long time ago, so you know it's not better. And then in January, he had a fracture of L1. Do you see, guys? Everybody see the fracture there? So minimum. I mean, you probably wouldn't do anything like that, just like a brace or maybe pain medicine. So this just shows the L1 fracture. Now he got uroseptic, as elderly people do, and what happened is the sepsis seeded the fracture. So now he's got osteomyelitis at T12L1. This was in May. So he was consulted. They put him on antibiotics. The osteomyelitis did not get better on antibiotics. It kept getting worse, kept destroying the disc, kept getting worse. Now there's an epidural abscess all the way around the fecal sac. You can see up on top there. Not only in the disc space, L1's completely gone, and now there's epidural abscess both anterior to the cord and posterior to the cord at the level of conus. So this is your problem. 93-year-old, he can't move. He said, I can't live like this. He can't even transfer in bed. He's bedridden. Got kyphosis, a fracture, infection of the whole L1 body. Mind you, L3, L4 is severely stenotic as well. You have some L4, 5 spondylolisthesis. He's 93, and his back pain is so severe he can't move. So what would you do for this guy?
It sounds like he's already felt sort of management.
He's got 3 months of IV vancomycin, and you can see this abscess is getting worse on the antibiotics. 3 months. He can't walk, can't do anything. So how would you approach it?
Flank approach, typical abdominal approach. Read that disc space in the vertebral body, put a big cage in there, and flip them over, decompress the epidural abscess as well as 3-4.
And then posteriorly, what would you do? He has severe stenosis at 3-4. Just ignore that.
Instrumentation, one level above, one level below where I put my cage.
So
Just decompress the
T11, L2, leave L3, L4 alone.
Well, I would decompress that level.
Okay, so just decompress 3-4. Okay, so I don't think there's a right answer. And what I did didn't work. I'll show you what happened. So I went back and forth with I didn't know what to do. I went back and forth a lot. So my plan was I wanted to decompress the epidural abscess. I instrumented from T9 I did everything posterior to L4. I decompressed L3, L4. And then at the level of the abscess, I did a very wide laminectomy. And then I also, in the front, I debrided it with a big rongeur. I exposed the spinal cord. And then from a posterior to anterior, I filled that whole defect with antibiotic cement. So I mixed, like you do with infections, I mixed the vancomycin in the powder. That whole thing is 16 cc's of cement in the front. I mean, that's not a cage, but it's not bad either. I mean, it totally filled the defect. And you can see how wide my laminectomy is. And you can see it's totally decompressed at the level of the abscess there from a unilateral approach, you know, the way I do it, unilateral laminectomy without decompression. This is 3-4 that I decompressed because he was stenotic. So this is his post-op x-ray. Now, his pain improved dramatically. He really didn't have much pain, and he could stand, but he didn't survive. He basically, 1 month later, he did go home, but his family couldn't take care of him, and he went to the hospice, and then eventually he died. So I just did it posterior. I don't think he died from my surgery, but it may have been his time to go anyway. But I thought this was an interesting case. I mean, I thought front back would be, I thought this would be less surgery for him. All right, that's it. That's all I got today. So any questions about?
Do you think it was just deconditioning from the 3 months of failed treatment? That he didn't survive, so he had to do rehab and stuff, or? I mean.
Why'd he die?
Yeah, I mean, like, or why couldn't he walk? I mean, he didn't have.
Thanks for coming, Samir. Yeah. Yeah, I mean, if you put you in bed for 2 weeks, you'll have a hard time.
Yeah.
You know, if you have the flu or something, yeah. So
93-year-old is, that's a big.
yeah, so 93, it's like they just didn't survive.
Oh my gosh.